Welcome, Dr. Beth Sutton. Dr. Sutton is, of course, the chair of the Board of Regents of the American College of Surgeons, and I'll add an editorial comment that it's been an absolute pleasure and privilege to be under her wing at the Board of Regents during this past year, which is, I am sure, a fairly unprecedented year for being a leader in any organization, and commend Beth for all you've done for the entire House of Surgery during this time, and welcome you, Dr. Sutton, for the interview.
Thank you. Thank you, Dr. Wexner. I'm honored to be asked.
Well, thanks. And Dr. Sutton, you represent a large swath of our fellows and members in that you're not in an academic practice in a university or major clinic, or as some of our international colleagues in a socialized health system where you work for the government, essentially. You're in a different practice setting. And so I'd like you to tell us a little bit, if you would please, about your practice setting, and then about some of the challenges that COVID-19 posed to you in that setting.
I'm in Wichita Falls, Texas, which is a city of about 100,000 in North Texas. The biggest city to the south is Dallas, about 2 hours away, and then Oklahoma City to the north, about 2 hours away as well. So we're a fair distance from the big academic medical centers, but we have quite a number of smaller towns around here. That's a big drawing area for us. We have been very, very fortunate not to have a large volume of COVID patients compared to many of the urban centers. But as everyone who watches the news probably has noticed, there are smaller cities that can have an outbreak of COVID at any time that can overwhelm their healthcare system. So our hospital is an independent hospital of about 350 beds. It's a level 2 trauma center with several centers of excellence and that kind of thing. They did, I feel like, a good job of organizing, sort of using their internal disaster plans to figure out how to be sure that there would be sufficient personal protective equipment and also personnel. As you, your listeners are all aware, the bigger medical centers commonly have done teams of personnel, nurses, physicians, etc., so that not everyone would be exposed on the same day if that were to occur. Our hospital did some modification of that with ICU staff and emergency department staff, but we're smaller. Within each specialty, we're a limited number. So of general surgeons such as me and acute care surgeons, there are about 9 of us total. So we sort of are each other's backup. We all take some calls. Some people take more than others, but we know that if 2 or 3 people get exposed, the others are going to have to step in. And it's just an understanding that's been present in this community for many, many years.
One of the things that we heard about a lot from the major academic centers and teaching programs is redeployment. You touched on PPE already, and you touched on teams, but what about redeployment? Were you expected to re-educate and during the ramp down and period of anticipation to be working in an intensive care unit or emergency department or elsewhere?
The physicians really haven't had to do that. The surgeons, at least, have not had to do that because we have not been overwhelmed with the number of cases. We don't have surgical residents here. So the concept that is present in a big academic medical center is not as easy to implement in that surgical trainees are not as long chronologically distant from when they ran a ventilator. Whereas some of our subspecialty surgeons would definitely have had to use those tutorials that were on the college website if we had to go back and run a ventilator.
One of the other facets of COVID-19, which has gained a lot of press, not only in the professional press, but in the lay press, is telehealth. As is, you work in an area you described that is 100,000 and 2 hours away from each of the two major closest cities. So perhaps it lends itself to telehealth. But on the other hand, those of us in academic centers can rely upon a large information technology infrastructure and or young trainees, very facile technology. What has been the impact of telehealth in your area, where geographically it would seem needed, but technologically could be challenging?
Yes, I think that's a wise observation. There was not much telehealth used here at all before the COVID crisis. The primary care physicians, I think, adapted to it quite quickly. The surgeons probably not as fast, but it did bring it to our mind that you probably really don't have to have the average patient drive all the way from Crowell, Texas, which is an hour and a half away, to look at a healing inguinal hernia incision, etc. The technology for those of us who, as you said, are not as young and technically facile is quite a challenge. And some of our patients have phones, but not sophisticated computers. And then, of course, the concerns about privacy and the ability. I don't worry so much about the picture of the patient that comes over my screen getting taken away by some hacker, but I do worry somewhat about a family member or a disinterested person in the home with the patient, such that the patient might not feel comfortable to share concerns that he or she might have that would negatively impact the interaction.
Understood.
And then also, interestingly, the hearing impairment. If people are hearing impaired or visually impaired, or as technologically impaired as I am, the combination can make it difficult to have a meaningful interaction.
Do you envision that once the pandemic, or at least the bulk of the pandemic, is behind us, that you'll continue to employ telehealth as you've recently been doing?
Yes, some. I have not embraced it as much as many people have, but we haven't been as busy, and we've been able to do quite a bit of follow-up just by audio. But yes, I think we'll get better at it and probably use it more.
In addition to some challenges with coverage and geographic challenges, there are certainly financial implications, which may be different in the private practice sector than in the academic employed world. And that one of the wonderful functions the college serves as the house of all surgery, representing over 85,000 members and fellows, is advocating for patients by ensuring that patients have access to surgeons. Perhaps you could talk about some of the college programs which have been introduced to assist fellows and members to ensure that their practices are there so that they can continue to care for their patients.
Well, the college has already had a limb of its advocacy for surgeons in different types of practices. So there's a handbook for surgeons in private practice, one for the employed surgeon, residents, that sort of thing. So they've expanded on that by making a sort of rapidly developing a practice protection committee, which is headed by Dr. Elsie and a couple of the other regents. And they've made it their business to interpret some of the financial benefits that are available. For example, the payroll protection program, the Medicare Advance program that the federal government funded to try to help small businesses, was applicable to surgeons in private practice because we are small businesses. But the nuances, most surgeons, whether they're in private practice or academic center, have never had to apply for a business loan, or unless they applied for a home loan or something like that. So the process is a little bit intimidating to physicians, I think. So the college advised our physicians to get in touch with their legal counsel and their accountant and use that guidance. But there have been webinars, there have been links to information from the Practice Protection Committee to really help surgeons who are employed or who are in practice struggling to get the help they need.
You mentioned information, and one of the areas where you've particularly led us forward where we've never been before is communication of information during the COVID-19 pandemic. And along with Scott Levin as our vice chair and our president and president-elect and Dave Hoyt and Corey Ashford in communications, we've had a fantastic group communicating COVID-19 information on a regular basis. As we transition away from COVID-19, perhaps this is an opportunity to explain to everybody how the college will continue to communicate information to fellows and members.
The COVID newsletter was the brainchild of Valerie Roosh, our current president, who felt that it was important to bring the immediately relevant information together in one place so that not only our fellows, but other surgeons and interested parties would know where to come to look for the information they need at the moment. And so the goal now is to transition that newsletter to a more inclusive document that will keep the focus on immediate relevancy, but bring in topics that may not be COVID related as that becomes appropriate.
Again, I'd like to thank you for all you've done in your tenure. It's been a pleasure working with you, and thanks for all you've done during the COVID-19 pandemic to keep everybody informed. Thanks for your time today and your insights, which I know will be immensely helpful to everyone who views and listens to the video. I appreciate it and look forward to seeing you. This video stuff is all great, but look forward to seeing you in person at some point in the future.
Yes. Thank you very much. I appreciate it.